The Vance once said, meet the mind of the patient before meeting the mouth of the patient. The timeless wisdom reminds us that truly understanding our patients' hopes, concerns, and expectations is just as important as any clinical procedure. And even with all the incredible advancements in dental technology, that principle still holds strong today. In this episode, we'll explore the unique challenges and expectations that come with treating prosthodontic patients, whether it's fixed or removable treatment, and how we as clinicians can better navigate those conversations.
Welcome to the Pillars Pod, where we explore the foundational values that shape exceptional dental professionals: excellence, ethics, professionalism, and leadership. Whether you are an ACD member, a dental student just starting out, a young practitioner finding your stride, or a seasoned dentist committed to growth, this podcast is for you. I'm Dr. Sonia Sluda, joined by my co-host, Dr. Syra Paradis, and together we'll be diving into a conversation with Dr. James Tonogai on managing the expectations and demands of the prosthodontic patient, a topic of everyday importance in clinical practice.
Dr. Tonogai completed his specialist training in prosthodontics at the University of Toronto in 2021 after earning his DDS from Western University in 2015. He practiced in Hamilton for 3 years before diving deeper into prosthodontics through advanced training. He's passionate about helping patients with complex dental needs and believes strongly in the power of clear communication and teamwork between specialists, general dentists, and patients. We're so excited to have you here, James.
Hi, Sarah. Hi, Sonia. Thank you for having me on your podcast. It's truly an honor to be here.
It's an honor for us as well, James. I'd like to start our discussion by speaking about patient expectations. How do you typically assess a patient's expectations before beginning prosthodontic treatment? And is there a role that referring dentists can play to manage their patients' expectations prior to the referral? And additionally, are expectations canvassed in your informed consent protocol?
That's a really great question, Sonia. So Syra mentioned a very well-known quote by Devan in the introduction to our podcast, which is, we must meet the mind of the patient before meeting the mouth of our patients. And as we all know, the initial conversations with a patient in the very first consultation are extremely critical to the success of any prosthodontic treatment. I may begin a conversation with a new patient with broad and open-ended questions, something like, hi, how can I help you? And then leave it up to the patient to guide me through their chief concern, their story, and the related history. I can then ask questions to clarify and take notes if necessary, depending on the depth of the history and the details the patient provides. Quite often, the tone and the pace of the patient's voice and their body language can tell a lot about their feelings, which can be tied to their expectations. Generally, I think of dividing expectations into outcome-based expectations and process-based expectations. For example, a process-based expectation might be a patient may expect treatment to be completed quickly, or a patient may expect treatment to be completed without taking impressions or without taking various other steps of that nature. And outcome-based expectations they may expect to be able to chew through a steak at the end of treatment, or they may expect the prosthesis to last X number of years as an outcome-based expectation. So it's difficult to cover all of the different possible expectation categories, but essentially I would say expectation management starts at the initial conversation and then continues throughout the entirety of the patient's diagnosis and treatment. As far as the informed consent forms, they're customized after a thorough assessment is completed and a treatment plan is agreed upon. I think that as far as referring dentists and the way that we can communicate together, I think the mutual respect and trust between referring dentists, specialists, and patients, that's the foundation that we can manage expectations on. I often enjoy discussing a case with a referring dentist on the phone before seeing the patient. And I think this is one way we can help to manage patients' expectations, because then a dentist can relay the results of this initial discussion to their patient and give them an idea of what their treatment may involve, both in the diagnosis and treatment aspects of care.
That's such an important point, James. And speaking of communication, these days patients are constantly influenced by social media, especially by smile makeover posts and flashy ads. It's a wave of information, and let's be honest, not all of it is accurate or even ethical. Have you noticed how these trends shape what patients expect from treatment? And when their expectations don't quite match what's realistic, how do you help bring the conversation back to what is realistic?
That's another great question. Thank you, Sarah. I think that cultural, social, and social media influences play a role in all parts of our lives, not just in dentistry. And these factors can unconsciously guide our patients' decision making and modify their expectations, for good or for bad, as you mentioned. It's great that we have a podcast like this one, which uses social media in a positive way to discuss ideas which are unbiased, evidence based, non commercially driven, and in the best interest of our patients. As we know, not all social media aims to achieve these goals. I think that there has been an expanded focus on cosmetic and aesthetic dentistry in our society, but I don't think this is always a bad thing when an extremely thorough and proper diagnosis and proper treatment planning is followed, which balances out the biologic, physiologic, and occlusal factors in providing the treatment. Every patient does deserve the right to improve their smile if they're unconfident with it. However, it's all about determining exactly what a patient does not like about their smile, and then determining the underlying diagnosis, and then formulating a treatment plan which is most appropriate for addressing their concerns. I'm personally not a big believer in removing sound enamel to fabricate porcelain veneers on virgin teeth when the patient is young and already has a relatively attractive smile, as I think the benefit to risk ratio is not that favorable. But of course, there are always rare exceptions to this, where thoughtful conservative preparation allows the benefits to outweigh the risks. Also, I believe that the difference between aesthetic dentistry and cosmetic dentistry should be thoroughly discussed with a patient early in the consultation process for anyone coming in for a consultation regarding treatment specifically to change the appearance of their smile. Aesthetics does not always mean perfectly straight and white teeth, as some irregularity can often be seen as beautiful. Cosmetic dentistry often focuses on enhanced aesthetics and a quote-unquote perfect smile. When a patient becomes engaged in the conversation with their oral healthcare provider about these factors, often their expectations come to the surface, and the provider can begin to ask further questions, which will help to determine the best path forwards.
So true. Expectations and sometimes unrealistic expectations can also be a big part of the conversation with our patients. But what about their demands? What are the most challenging situations that you have faced with patients in terms of demands, and how have you found it best to handle these situations?
That's another great question. Definitely, unrealistic expectations and demands can create a sense of tension in the initial consultation. And I often feel that needs to be addressed as early as possible to avoid unpleasant treatment experiences for both the clinician and the patient. If a clinician feels that a patient's demands are challenging or, worse yet, clinically impossible to manage, one can always consider referring the patient to another clinician for an assessment and/or treatment. So sometimes I feel demands can stem from a general fear of dentistry or from limited oral health literacy, where a patient really just doesn't understand what the various treatment options involve. For example, I remember a patient once came for a consultation for maxillary clearance and an implant-supported fixed full-arch dental prosthesis in the maxilla. Clinically, the patient presented with poor oral hygiene, several missing teeth, and severe caries on all remaining teeth. She reported having significant tooth pain on almost all teeth and had heard from a friend that she should get implants because, quote unquote, implants cannot get cavities. So we proceeded with the consultation, and the patient's demand was that she wanted to avoid having any extractions at all. She just wanted to have implants. And so it was clear that the patient didn't understand that implants were meant to help with tooth replacement and not to strengthen the teeth that are existing. So there was just a terminology divide there. And so the patient's demand came from a lack of understanding. And so in hearing this, I presented some demonstration models and some photographs, and we had a conversation of what implant treatment would involve. And after that careful discussion, the patient better understood what treatment involved and understood that her initial demand was quite impossible. And so then after aligning our vocabulary and knowledge, we could then move forward with meaningful discussions. So sometimes demands are just a start point for further discussions, I would say.
That's a great insight, actually. Let's talk more about patients' demands. In your conversations with colleagues, do you feel patients today are more demanding than in the past? Or is it more than they are overwhelmed by the sheer volume of information, some of it misleading, of course, and trying to make sense of complex treatment options? How do you help your patients to navigate through this?
So thank you very much for the question, Sarah. I think I would defer the answer to my mentors in prosthodontics who have been practicing for more years than I have. I don't know exactly the trends of the past, but generally, I think that there have always been demanding patients forever in the history of dentistry. If we look back into the historical literature on denture patient psychology, even as far back as the early 1900s, there was talk about the demanding or exacting, quote unquote, patient. House in 1950 published the House classification of philosophical, exacting, indifferent, and hysterical patients. And I think this classification system is useful to consider to this day. In the age of the internet, which we're currently living in, I do think that the ease of access to information is both a gift and a curse. So, information on the internet and social media is not vetted for accuracy, and we know it's filled with commercial bias. So, as clinicians, we're lucky to be trained to understand the value of critical appraisal, and we understand when research is conducted with solid methodology and scientific rigor and when it is not. Patients, unfortunately, don't have this lens to screen out what they're reading. And I think it's our role as ethical healthcare providers to know the best evidence literature and ensure that our patients are well informed of their treatment options and what is realistic and what really the treatment involves. The process of informing our patients definitely takes significant time. And sometimes social media and the internet changes the way they see things. And then we have to maybe teach them to unlearn those things. It's important if we're going to truly provide patient-centered care to take our time with these conversations.
Great advice. And circling back to what you just said earlier, it seems that unrealistic expectations are the root cause of unrealistic demands and the clinging to unsubstantiated science. In your experience, or in the experience of your fellow prosthodontists or general dentists doing complicated prosthodontic treatment, what would you say are the most common unrealistic expectations that patients in general have? And can you speak to how you temper those expectations?
So I feel that dental implant treatment is a common source of patient confusion and unrealistic expectations. Of course, dental implant treatment is likely one of the most important dental advances we have had in our profession, and almost certainly it's improved the quality of life for many, many patients. And as a graduate of the University of Toronto Graduate Prosthodontics Program, the starting point of dental implant treatment in North America after the Toronto Conference in 1982, implant treatment was a large part of my training, and I had the privilege of learning from many renowned experts in the field. Now, implants, they're similar to natural teeth, and patients often feel they're the same as natural teeth, which is a common misconception. They are very similar, but not exactly the same. So, for example, patients sometimes note a difference in the feeling of their implants, whether it's a full arch or single implant treatment. They notice a difference in the feeling of the final prosthesis, which they may not have expected when they started treatment if it wasn't mentioned to them in the initial consultation. And we know that implants do not have any proprioception, no periodontal ligament, so there are limitations in that aspect of things. In addition, patients often think the implants will last forever. And although, of course, we aim for this to be true, mechanical or prosthetic complications can often occur due to force-related factors or oral hygiene-related factors. So, for example, peri-implant tissues can become compromised over time with poor oral hygiene, resulting in biologic implant complications. And some patients aren't aware of that when they start treatment. So it's very important that we go over that with them. And there's several other factors related to implants, but there's too many to discuss in this limited time we have today. So suffice it to say, I think we should be very careful with our initial consultations with patients for implant treatment.
With so many options, especially regarding a multi-stage complicated treatment plans, it could be quite overwhelming to patient trying to make the best decision on treatment. How do you explain the pros and cons and limitations of complex dental strategies and treatment plans in a way that patients fully understand the process and their options?
Great question, Sarah. So I completely agree with you that in some cases, there's so many options available to our patients and so many variations within those options that it can be overwhelming for a patient. So basically, everything starts with a thorough diagnostic assessment, radiographs, possibly a CBCT scan, mounted casts, photographs, and a periodontal assessment, and presenting these findings to a patient to help them understand that relationship between their chief concern and expectations to the clinical findings and diagnosis or problem list. I think that's the start point before we start introducing treatment options. So an understanding of the diagnosis and clarifying the relationship between the chief concern and the diagnosis, once that step in the process is completed, I think then it sets a nice platform for discussing the treatment options. Once the patient understands their own diagnoses, then I usually start with a discussion of general concepts of treatment options available. And I use pre-written information booklets, photographs, and demonstration models. And the booklets themselves outline the general risks, benefits, and alternatives of the treatment options in a patient-friendly language. Oftentimes, I'll give the patients these booklets to take home and read and discuss with their family members so they can incorporate other people's thoughts into their decision-making. Sometimes a second or third consultation is necessary to arrive at an appropriate treatment option, and sometimes finances need to be investigated in the interim time between the consultations. In short, basically, each case is very unique, and some may take longer than others to ensure the proper understanding is reached, to ensure true informed consent and expectation management.
Great advice. I've often found, though, that in the case that postoperatively, even if the treatment was complex and well explained, the patients see it as one and done, despite instructions to the contrary. What is the most effective way to educate patients on the long-term maintenance and precautions associated with prostheses, and is the necessary follow-up addressed in the informed consent at the start of the procedure?
That's a very good point. Very good point. So I completely agree, Sonia, that patients don't always understand their responsibilities for long-term success. And I think that having a section of the information booklets which covers maintenance is extremely important. And also a discussion of where the maintenance and hygiene visits will be completed is also very important. This discussion should definitely be had before treatment begins. But also after prosthesis insertion, a few minutes of time should be dedicated to showing patient the optimal oral hygiene measures around the prosthesis. This is sometimes tough because at the end of inserting a prosthesis, we can sometimes be running over time or we might be in a rush. But that last 5 minutes, last 10 minutes is absolutely critical to the longevity of the prosthesis. Some patients might require significant instruction at that time as well, because either due to dexterity issues or challenging contours of the prosthesis. So it's important to note that the hygiene access has to be either made larger for the patient or they really have to be shown with a mirror where it is that they can clean the prosthesis for fixed prostheses. And finally, at every follow-up and recall visit, that patient's oral hygiene routine should be reassessed for adequacy. And the prosthesis also should be assessed for plaque accumulation and tissue health.
Dr. Tonogai, thank you so much for sharing your experience and wisdom. Managing patient expectations and demands is not an easy task, and your thoughtful approach is a great reminder of how much our profession is about connection, but also clear communication. It's been a real pleasure having you on the Pillar Spot.
And we would like to thank you, our audience, for joining our discussion today. Be sure to follow us on Instagram at ACD Ontario or on Facebook for upcoming Pillar Pods episodes released each month.
That's goodbye for now from Zaira and Sonia, your Pillar Spot hosts. Thanks for tuning in into the Pillar Spot, where we keep the conversation real, helpful, and grounded in the values that shape great dentistry. Thanks for listening, and we'll see you next time.